Thank you so much for inviting me, and I'm really excited to talk a little bit about a big part of life for many of us as we approach perimenopause and menopause. This is a new experience for me doing lectures completely on WebEx, so hello to everyone, and hopefully I won't talk too fast. So my name is Sabeen Chaudry, and as we discussed, I'm going to be talking a little bit about what happens as we age and women's cardiovascular risk with aging. So I just wanted to go through a little bit of an outline of what I'm hoping to discuss today. I wanted to review changes that occur in our bodies around menopause and how that impacts our heart specifically, discuss risk factors for heart disease as we age, and talk a little bit about the cholesterol guidelines and management, as well as review blood pressure guidelines and management, both of which have changed a little bit over the last 5 to 7 years. Talk about lifestyle modification and managing risk factors of heart disease. And then, very importantly, also discuss the signs and symptoms of heart disease in women and differences in heart disease in women. Menopause can occur very suddenly, and it can also be more mild in women. There are varying degrees of frequency of symptoms, and for most women, it starts with changing in their menstrual cycle, changes in mood, and hot flashes, as well as trouble sleeping and weight gain can be some of the symptoms. Many of us will have changes in interest in our sex and vaginal dryness, among other things. And then we have changes to bone density, changes to our cholesterol, thinning hair, headaches, and all of this is really brought on by loss of estrogen that starts occurring in our mid to late 40s. Menopause is a normal, natural event for most people. It's defined as the final menstrual period and confirmed 1 year after you've had no menstrual bleeding. It represents a permanent cessation of menses, and typically that results from loss of ovarian follicular function. Our ovaries are the big source of estrogen, and typically that's due to aging, though there are other types of medical issues that can cause that, including surgical removal of our ovaries or uterus. In some patients, loss of function due to chemotherapy or radiation, and then iatrogenic causes and premature menopause as well. Postmenopause is the time that comes after. And for many of us, especially in North America, with our current life expectancies, this may make up a third to even a half of our lifespan. I won't belabor this too much, but on the left, you see the kind of normal hormonal changes that happen with the menstrual cycle. And the follicular stimulating hormone is a big part of how we release estrogen from our ovaries. And over time, basically with changes that occur in our hormonal patterns, we just don't release the same amount of estrogen. And you'll see on the right the graphic of kind of what occurs as we're getting into perimenopause and then into the postmenopause period, where those hormonal changes continue and estrogen continues to decline. And this just to kind of talk again about all the different things that occur with menopause, and certainly along with all the different symptoms we may be feeling, there is worry and discomfort and just concern over the changes that we may be feeling, and that's all very normal as we enter this different phase of life. As we age, we have changes to our estrogen levels, which become very important as we talk about cardiovascular health. So you can see, in our 20s into our 30s, we're kind of starting to increase our estrogen level and really peaking in our mid 30s. And then from there, you continue to decline. And by the time you're in your 40s and 50s, most women are hitting menopause. And then our estrogen levels really kind of precipitously decrease as we hit that postmenopause phase. And by the time we're in our 80s, you can see just our feet have a little bit of estrogen. As our estrogen levels decrease, there are also a range of symptoms we may be experiencing. And typically we think of hot flashes and the irritability and not being able to sleep. But then as we get older and we've had loss of estrogen for longer, we start to have the cardiovascular effects and things like changes to our bone density, as well as changes to skin and hair loss and cognitive changes as well that can occur. And this is just another graphic that goes through some of the same types of information, really showing all the different organ systems that can get affected as we approach menopause, and some of the symptoms that can go with that. Now, the cardiovascular effects of estrogen are really where I'll spend a little bit more time, and the part that I find to be very interesting. It's really amazing to me how many different organ systems estrogen has an impact on. And for the cardiovascular system, we describe it as having pleiotropic effects, meaning that it really affects many different parts of our functional system, and in different ways as well. In terms of our cholesterol, it starts to affect our lipid panel, and we will see an increase in the LDL or bad cholesterol as we get older post-menopause, and then a decrease in the HDL. Particularly in the absence of estrogen, we tend to accumulate the small particle LDL, which is the bad kind, the kind that we worry about leading to vascular plaque and atherosclerosis. Estrogen has been noted to help decrease inflammation and help with metabolism and insulin sensitivity. It has functions on our vascular tone, as well as within the heart cell itself, which is called the myocyte. We know that estrogen helps in the compliance of blood vessels, so the ability of blood vessels to kind of dilate and relax, and it can help inhibit some of the hormones that constrict blood vessels. And so as we lose estrogen, one of the things that happens is our blood vessels don't have that nice elasticity and compliance. They get a little stiffer with age. It also has bearing on inflammatory response and immune cells, and it acts on our blood pressure system as well. And that's one of the reasons we see increasing blood pressures as we age. It acts on our heart cells to regulate some of the heart, what's called repolarization. So really at the cell level, regulating how the cardiac cells may be behaving in different settings and with different medications. And these are all followed in animal models and to some degree in human studies as well. And despite years of evaluation, we still don't completely understand all the ways that estrogen may affect different parts of our body and certainly different parts of our cardiovascular system. And I'll get back to why some of that's important as we continue to talk. To take a step back from estrogen itself, I wanted to talk a little bit about how our cardiovascular disease risk changes as we get older. And, when we're younger, we know that smoking, both regular cigarettes and e-cigarettes, increase risk of heart disease as we get older. When you compound that with birth control, that also increases your risk of heart disease. And the nice kind of thing I just want to point out with this graphic is some of the relative risk increases that occur with some behaviors. When we have our pregnancies and we gain weight and are unable to lose that weight, again, that weight gain and obesity increase our risk of heart disease. And then over time, as the LDL increases. Some things that people may not be aware of are autoimmune disorders can increase risk of heart disease, and certain pregnancy conditions like having had preeclampsia, diabetes in pregnancy, or high blood pressure in pregnancy also increase your risk of heart disease later in life. Having preterm babies can do that, and some of that is because they often will go along with these other pregnancy-related conditions. Certain cancer treatments will also increase our risk of heart disease later in life. And then diabetes and high blood pressure, which I think most people probably have heard will increase risk of heart disease. For diabetes, you may be 2 to 3 times more likely to develop heart disease in your lifetime. And with high blood pressure, it really affects up to 75% of women by the time we're getting in our 70s and 80s. And I'll speak to that in a little bit as well. And the other kind of risks that we don't talk about as much are things like depression. And we know that stress and psychological stress and depression can also contribute to increasing heart disease. And this graphic kind of talks a little bit to some of those psychosocial factors. And again, kind of looking as we age at different elements in life that may increase our risk of heart disease later in life. And also thinking a little bit about the other types of heart conditions that we may be affected with. So often as infants and young children, we worry about congenital heart disease, so things that you're born with. And then with aging, we have the pregnancy-related issues and other types of illnesses that may be more viral or bacterial mediated. And then as we're hitting middle age and older, we get to the age-related issues where heart blockages become an issue, things like congestive heart failure, heart rhythm changes, vascular disease, and valvular heart disease. So aging of our heart valves, like other parts of our heart, all become issues as we get older. I wanted to talk a little bit about some of the global impact of heart disease on women. And this graphic, hopefully you guys can see it okay, but it kind of looks at different continents and areas in the world to look at what the spread of heart disease is and what women are dying of. And this is actually a commission through Lancet, which is a medical journal where they are looking to reduce the global burden of women's heart disease by 2030 and some of the information they're collecting. So what's really interesting is that we are in high income North America, which is right here. And the kind of lion's share of burden for us is ischemic heart disease and stroke. And you'll see that that makes up really a large part of what women are dying from in the United States and North America. And this graphic similarly is looking at global patterns of different risk factors for heart disease. And again, we are right here in the high income North America. And you can see that a very large part of what is driving our death is high cholesterol and high glucose. And those are, important issues as we all get older. I wanted to touch base a little bit about prevention and risk management. And I think it's hard to really talk about aging and heart disease without mentioning the important ways that we try and keep ourselves healthy and reduce our risk of developing heart disease in the first place. In 2019, the American College of Cardiology and American Heart Association came up with a whole new revised set of guidelines to really encourage people to work on preventative measures. And part of that was encouraging regular exercise for at least 150 minutes a week. And they define that as having moderate activity for that time frame. Since those guidelines came out, there was actually a paper in the last year suggesting to really improve your risk of heart disease, you probably need to be closer to 300 minutes of moderate exercise. But I think starting at 150 is a really great place to get yourself healthier. A healthy diet, and for the American College of Cardiology and AHA, the DASH diet and the Mediterranean diet are the two diets of choice, and we'll talk a little bit about that. Low sodium intake is another cornerstone that is incredibly important in reducing the likelihood that we'll develop things like high blood pressure. And smoking cessation as well is incredibly important. Limited to no alcohol intake. And again, over the last year to 2 years, a number of studies have looked at alcohol intake and really pretty consistently shown that even moderate levels of alcohol intake can increase our mortality, so our likelihood of dying. They can increase many cancers and certainly from a heart disease burden risk, as well as developing other types of risk factors. It's something that we want to be very cautious about. In women, moderate alcohol intake is considered 3 drinks a week, which doesn't really seem like a lot, and that's enough to start to increase some of these health risks. And then the other important part of this is if you've developed things like high blood pressure or diabetes or high cholesterol, we want to make sure that we're treating your risk of associated diseases to really help reduce your risk of heart disease as much as possible. And this graphic goes through the same concepts, and this is also from the AHA-ACC guideline from 2019. So looking at those cornerstones that are so important for prevention of cardiovascular disease, managing blood pressure, so trying to avoid getting high blood pressure, but if you have it, making sure that we're treating your blood pressure, looking at your cholesterol levels, and again, looking at your risk related to your high cholesterol and making sure we're giving you the right advice about how to manage that. Not smoking, being at a healthy weight, treating your diabetes if you have it, exercising regularly, as I mentioned, and aspirin is on this graphic as well. Those guidelines have changed a little bit over the last few years. So for quite a while, we used to recommend a baby aspirin prophylactically to many patients as a way to reduce their risk of having a heart attack or stroke if they had never had one before. The most recent trial data really hasn't shown that to be effective in reducing risk of cardiovascular events in the general population. And there's some data that it may increase your risk of bleeding. And so a few years back, both the FDA and the American College of Cardiology dialed back some of those recommendations to now not broadly recommend it for primary prevention, but still include it for those patients who may be high risk. So if you're someone who's older with diabetes and high blood pressure, you may still want to take a baby aspirin for primary prevention, and that's a good topic to touch base with your regular physician about as well. If you've had a heart attack or stroke, you are in a different category, and there is very good data that those patients should continue a baby aspirin lifelong. So I apologize, this is a little busy, but this is one of our important risk calculators for assessing your cardiovascular risk and then the role of statins. And I think what's particularly helpful about this is taking a look at kind of where you are in your age and what other types of risk factors you have, and really using that as a guide for, does it make sense to start cholesterol lowering therapy? And are you in a bucket where we should be a little bit more worried about your heart disease risk and want to be more aggressive with how we're managing your risk? So as you can see, you know, as we're young, up till the age of 20, really lifestyle modification is the mainstay of how we want to encourage people to reduce risk. And even into your 30s and 40s, that may still be the primary recommendation. Though as we get older, if we have a strong family history of premature coronary disease, definitely if our LDL absolute numbers are greater than 160 or 190 as you get older, those would be absolute indications to start a statin. And I'll discuss the risk calculator in a little bit, but some of the things we want to kind of think about as we're tailoring the discussion to each individual patient's risk is other risk factors that might be present for them. So the risk calculator that I will show you in a few minutes talks a little bit about age, your blood pressure, things like diabetes and smoking, but certainly we know that other risk factors may also increase your risk of heart disease. So inflammatory diseases, some of the conditions in pregnancy that I had mentioned, things like chronic kidney disease can all increase your risk of heart disease. And while that doesn't come into our equation for your 10-year risk of heart disease, it may still be an important factor in deciding, is it time to go ahead and start the statin and try and reduce your risk of heart disease as much as possible. And those are where those risk reduction discussions become incredibly important. Many statins at moderate doses will help reduce your risk of heart disease and your LDL by 30 to 40%. So they have very good data behind them about improving your risk profile, and that is a big reason that we recommend this class of medications. When the cholesterol guidelines changed a number of years ago, we started to move away from non-statin cholesterol lowering medications specifically for this reason. Statins have been shown to really improve your risk and reduce your risk of heart disease in a way that many other medication classes have not. And so that is why you see that as the focus of the discussion at this time. And this slide just shows with our risk calculator, this was the trial called the REGARD study that helped validate that what we thought would help predict heart disease risk really in the real world population was similar to what the predictor was calculating for people. So this just shows you that those two things do mirror each other. When you see your doctor and they're talking about the pooled cohort equation, this is the app that we have from the American College of Cardiology that helps us give you some numbers on what your heart disease risk may be. And part of what the calculator will do is take your age, your gender. It has a little bit of information based on race, but unfortunately, we just don't have broad information about racial differences, even though we know they exist. Your cholesterol profile, your blood pressure at that time, and then other types of risk factors like high blood pressure, diabetes, and smoking. And it allows us to give you a 10-year risk of heart disease, as well as a lifetime risk. The lifetime risk caps when you're in your late 60s. But it's a great way to kind of assess for you in this moment what your risk is. And as I said, some of these non-traditional risk factors are not part of this equation. So it is important to still have that tailored conversation to really think about what is right for you as the individual patient. So I touched base a little bit on some of the risk factors in our medical health that can increase our risk. There are some other risk factors that have been shown to, again, help predict increased risk in some patients. Homocysteine and cardiac CRP are two inflammatory markers that can be checked in your blood. And having elevated readings can, again, suggest that you may be at higher risk of heart disease, and that starting a statin may be an appropriate choice for you, even if your cholesterol numbers don't look too bad. And then the other item that's been particularly helpful is calcium scoring, and you may have heard about this a little bit. Calcium scoring has been around for a while now, though I think it tends to fall in and out of favor. More recently, it has been recommended again by the American College of Cardiology as an additional resource in helping people make a decision about their cardiovascular risk and whether statin therapy would be appropriate. And then some of the gender-specific risk factors I had mentioned earlier. So just talking a little bit more about how the calcium score works. If you're someone who has elevated cholesterol or due to age and their other risk factors, would be recommended a statin. The addition of a calcium score really isn't going to help that much. But really, for those patients who were not sure whether they should be on a statin, maybe their 10-year risk of heart disease is less than 5% or less than 7.5%, which is the current cutoff where we make those recommendations. The additional information of what your calcium score is may help sway you one way or the other as to whether it's appropriate to start a statin medication. If your calcium score is 0, it means you have no calcium in your heart arteries, and that is checked with a CAT scan of the chest, where we basically quantitate or add up the amount of calcium we see in the heart arteries. So your risk of plaque buildup is very low in that setting. It is possible to have plaque without calcium, so it doesn't mean that they will, there's nothing in the arteries, but it certainly speaks against more progressive plaque, and that's an important distinction. And then as you get to the more moderate range of 10-year risk for heart disease, it helps us kind of gauge whether, again, you're in that lower bucket or higher bucket where statins would be recommended. And then as you get over 7.5% for your risk of heart disease in the next decade, it really, or over 20%, you're going to be recommended a statin, and the addition of a calcium score almost becomes irrelevant in how we recommend risk reduction as we kind of look at aging and risk modification. Changing gears a little bit, I wanted to also talk about the blood pressure recommendations, and that also changed about 5 years ago. Prior to that, we were saying that blood pressure readings up to 140/90 could be considered normal, but the guideline changes have now made 130/80 the benchmark of our top number that we want to see people at. And really, the ideal blood pressure is being less than 120/80. In between 120 to 130 for that top measurement is considered an elevated reading and pre-high blood pressure. And the blood pressure trial data that this is based on is almost 20 years old now. And we know from that trial, or those series of trials, that the lower that top number got, the better people did. So they had lower rates of heart disease and stroke. And the last decade that we had looser recommendations, we were certainly seeing higher numbers of those types of events. And that's part of the reason that the guideline has kind of switched back to being more aggressive in treating high blood pressure and trying to reduce people's risk of having things like a heart attack and stroke. Why is high blood pressure bad? There are important studies that were done almost 30 years ago now as part of the Framingham Heart Study that helped us see really the importance of high blood pressure in contributing to heart attacks and stroke. And these two graphics will show you, both in men and women, that when you have elevated blood pressure readings and the higher that top number got, the higher your event rate of cardiovascular events. So heart attack and stroke basically became more common the higher your top number blood pressure got higher. And when you add diabetes to the mix, which is what your green column is, you can see that those rates of heart disease and stroke really skyrocketed. So the two together are a bad combination. We want to make sure that we're addressing those in patients. And this graphic, again, from the American Heart Association and American College of Cardiology, looks at the prevalence of high blood pressure as we get older. And I think I had mentioned a little bit with aging that 75% of us will develop high blood pressure. And if you look kind of in the age brackets, by the time we are getting into our 60s and 70s, about 70 to 80% of this patient pool reported being on a high blood pressure medication or having blood pressures greater than 130/80. And then that number, even for high blood pressure readings of 140/90 or being on a blood pressure medication, stayed pretty consistent in the two buckets and pretty consistent in both men and women as well. So as we get older, the rates of high blood pressure really increase. Another important topic I just wanted to touch base on is, where we see high blood pressure and how we should be thinking about it. And there are definitely patients who have normal blood pressure readings both at home and in the office setting, and we consider them as not having high blood pressure. And then the other group is those who are persistently high, and we definitely consider them as having high blood pressure. The other two groups that sometimes can be a little harder to diagnose are patients who seemingly have normal blood pressure readings at rest or in office visits, but in actuality, in a good part of their daily life or home life, their blood pressures are elevated, and that does cause hypertension or high blood pressure. And for others, the exact opposite, which is that in the office setting, they're a little nervous and their blood pressure is elevated, but in daily life, they don't have that issue. And that really is considered white coat hypertension and less concerning in the bigger picture for treatment. We have a lot of ways we can treat blood pressure, and I wanted to include this graphic because I think it's helpful just to see, as we talk about lifestyle modification, how much can we really improve our blood pressure reading. And different types of interventions will have a different effect on our blood pressure readings. So when we have high blood pressure, losing weight and getting to an optimal body weight may help us reduce that reading by 5 millimeters mercury. The DASH diet, which is what the American College of Cardiology promotes for healthy lifestyle and reducing high blood pressure, may reduce that top number by 11 millimeters mercury. Things like reducing your dietary sodium and getting under 1,500 milligrams a day. So that's not quite half a teaspoon for everything that you're taking in. Will get you about 5 to 6 millimeters mercury of reduction. And improving your dietary potassium. So potassium intake actually can help improve your blood pressure as well. And that may reduce your blood pressure reading by 4 to 5 millimeters mercury. Things like physical activity are also incredibly important in helping us improve our blood pressure readings, and we can see adjustments of anywhere from 4 to 8 millimeters mercury depending on how much exercise we're getting in. And then finally, being mindful of our alcohol intake and actually reducing our alcohol intake will help improve our blood pressure as well, and we may get a change of about 4 millimeters mercury with that change in lifestyle. This leads to our recommendations from the American College of Cardiology and AHA, and this changed in 2017. So again, this kind of is a different way to look at the things we were just talking about. Normal blood pressure is considered less than 120/80. High blood pressure and pre-hypertension is considered 120 to 129 for that top number. And then you're in stage 1 high blood pressure when you're in the 130s for the top number. And then after that, when you're above 140 for the top number systolic reading, you're in stage 2 high blood pressure. Lifestyle modification is recommended for many of those initial stages, and we continue to recommend lifestyle modification regardless of what stage you're in. But as you get into stage 1 high blood pressure, and definitely if you have other risk factors for heart disease, we want to add a medication to help treat those high blood pressure readings. And in addition to lifestyle modification, we want to start thinking about pharmacologic therapies or medications to really help reduce your blood pressure and get it to a normal range. And then the goal is to continue to follow that until you're in that normal range and make sure we're making medication and lifestyle adjustments to get you there and not just leaving it alone. The last topic I just wanted to touch base on a little bit in risk modification was obesity and the changes in obesity with time in the United States, which I think is incredibly important as we talk about where we are with heart disease in this country. When you look at these different graphics of the United States, in 1990, which is this primarily blue graphic, you'll see that the majority of the country had under 10 to 15% of its population in most states qualifying as being obese. And really, I think the highest states are these darker blue, and this is the 10 to 15%, and everywhere else is 5 to 10 or less. And then as each decade progresses, we are increasing our rates of obesity in the United States, and particularly in the South. You can see that that tremendously starts to change. And by the time you're in the 1990s, half the country has about a 20 to 30% population that is considered obese. And unfortunately, this graphic is our current population information. And now we do not have any part of the country that has a population rate less than 20 to 25% obesity, which is such a stark change when you consider where we were just in the 1990s. And then, almost half the population in some of these southern states qualify as being obese. Getting back to the importance of lifestyle modification in menopause, the reason we talk so much about these changes is not only for our cardiovascular health, but also because many of these changes can help us feel better during menopause as well, and getting good sleep, regular exercise, trying to be careful and mindful with our alcohol intake and refined sugar intake, and making sure that we're having lots of healthy foods in our diet, and avoiding smoking and getting regular exercise are all important cornerstones in helping some of the symptoms that we develop, along with reducing our risk of heart disease. Our heart healthy diet, the more colorful we can get it, the better. And I really love this graphic because the idea of having a rainbow on your plate, I think, is so important for a heart healthy diet. And really, as time has gone on, I think more and more we're finding that the more our diet can be plant-based and the more we avoid processed foods, refined sugars, and really animal protein, the healthier we can be and the lower rates of heart disease we will have. So I can't emphasize enough the importance of this concept of really having your fruits and vegetables and having that be the primary part of your plate. And that leads me to the DASH diet, which is promoted by the American College of Cardiology and American Heart Association as a very healthy diet and a good choice, particularly for reducing high blood pressure. Though I think from a lifestyle standpoint, it really can help with many different medical disorders and just staying healthy. So this kind of goes through a little bit of the different food groups that are healthy to have and how much we want you to be having of them. And I have to apologize because I didn't have the rest of the text with this, but servings in this case are going to be a lot less than what we may consider a serving. So we want to focus on whole grains, which really are much healthier for you than refined white flour or white rice. A serving of a whole grain in this diet is 1 slice of bread, 1 ounce of cereal, or a half a cup of cooked rice, just to give you a sense of kind of what that 6 to 8 really means, or 4 to 5 really means. Servings of vegetables, at least 1 cup of raw vegetables or a half a cup of cooked. And I think for vegetables, I would say you can definitely have more and not have to worry about deleterious effects in your diet. And same with fresh fruit, 4 to 5 servings. When we think of dairy, which is recommended at 2 to 3 servings, a cup of milk or yogurt is a full serving, and 1.5 ounces of cheese is considered a serving. And for meat, each serving is 1 ounce. So that's not a lot in the current American diet, but really, with each meal, we think of a typical serving being about 3 ounces. Nuts and legumes and beans, you want about 1/3 of a cup. 1/2 a cup of cooked beans or peas is a serving. And then when you think of things like peanut butter, 1 tablespoon is considered a serving, just to give everyone a sense of what these numbers mean. And the sugary treats that are still on this, really they're recommending limiting table sugar and having refined sugar very minimally. 1 tablespoon is a serving of that, and things like sorbet, 1/2 a cup of sorbet is a serving, and 1 tablespoon of jam is a serving, and all of that counts towards your weekly allowance. So I wanted to switch gears a little bit as we talk about now moving away from lifestyle modification to hormone replacement therapy. And especially in light of all those great things I was mentioning that estrogen does, one of the, I think, thoughts that people had over 30 years ago was, geez, why not just use hormone replacement therapy? Estrogen does all these great things. We can just pop a pill and basically mimic all those great effects and reduce women's risk of heart disease by doing that. If only it were that easy. And unfortunately, despite a lot of optimism about that being a potential treatment to reduce heart disease, a couple of large trials, including the Women's Health Initiative and the Million Women Study, really bore out that that's not the case. And in fact, almost the opposite was happening. And in those trials, there was increased risk of blood clots, increased risk of cardiovascular disease and stroke, and increased risk of breast and uterine cancer with hormone replacement therapy. So subsequent to that, we kind of really shift gears and stopped recommending hormone replacement therapy as a treatment to prevent cardiovascular disease. I would say that the pendulum is kind of swinging the other way again, and not so much that it's being recommended for prevention of cardiovascular disease, but the questions are being asked as to, are there other formulations we need to be thinking of, and really kind of going back to the research lab to say, geez, can we get this right? And was it something that was being done that was not right to mimic the way estrogen is in our body? And one of the particular criticisms of many of those trials were that really each of these studies used different formulations of estrogen. Some of them combined estrogen with other hormones like progesterone, and there wasn't a consistent dose or combination that was used to really be able to vet out, is it really something we just need to find that right combination of, or is it across the board that the problem exists? So I think this is going to be a to be continued topic. We are still doing trials to better understand this and be able to give patients the right recommendations. Hormone replacement therapy absolutely is still used to help with symptoms of menopause. So I think really the question is, what is your risk either of cancer or heart disease? And does hormone replacement therapy, is it still an appropriate choice depending on what your other risk factors are? So for many women who don't have cancer risk in their family, or have low risk of breast cancer, or low risk of blood clots or cardiovascular disease, hormone replacement therapy may absolutely be appropriate to help manage some of their symptoms of menopause. I think as you develop other risk factors, and definitely if you have a predisposition towards cancer in the family, you may just want to have that conversation with your providers about what the risks of hormone replacement therapy are and whether they're still something you want to consider. But for prevention of heart disease, right now there is no data that this is helpful. And this just kind of underscores that same information from one of the Lancet commissions looking at global impact of women's health, and then particularly in estrogen. And unfortunately, even more current trials have not borne out an reduction in cardiovascular risk with the use of estrogen. I wanted to take a few minutes to talk about women and heart disease. And so, we've had a lot of talk about ways to prevent heart disease and what happens as we get older. Heart disease, and particularly heart attacks, cardiovascular disease, is the #1 killer of women. And as we get into our 60s, it is the leading cause of death in women. Cardiovascular disease includes coronary heart disease and stroke. In younger age groups, it's the second leading cause of death in women. And as I just mentioned, it's the leading cause of women over the age of 65. Increasingly, we're seeing younger women in their 30s and 40s having cardiovascular disease and presentations of heart attacks. And really, this is being thought to also be driven by increasing obesity and diabetes and high blood pressure, among other risk factors in younger and younger patient populations. So for the first time in about 40 years, we're seeing a lot of those rates of heart disease increase in women. This graphic just talks a little bit about some of what I've talked about. So we have traditional risk factors for heart disease, like high blood pressure and diabetes and elevated cholesterol. And then the non-traditional risk factor bucket, which is so important, like how much weight did you gain during pregnancy? Did you have diabetes during pregnancy? Things like premature delivery, preeclampsia, and how old you were when you had menopause. And heart disease has a large, big umbrella, and we think of ischemic heart disease as having heart attacks, but that type of plaque buildup can happen in our other blood vessels, and we call that peripheral artery disease. We know that congestive heart failure also becomes increased in women as we age, and strokes become increased as we age. As our weight goes up, we develop things like sleep apnea, and that also can contribute to our risk of heart disease. And then other types of disorders that go hand in hand with that as we get older. Heart attack symptoms in women can be very different. And this graphic just goes through a little bit of what a woman might feel. We think of that clutching chest pain that you often will see on TV. But for women, those symptoms can be far more subtle. And sometimes it is just being nauseous or vomiting. Many women will actually have their pain in their neck or jaw area and not the chest. The shoulder blades can be another place that people may feel their symptoms in a heart attack. Trouble breathing or fainting, a sensation of indigestion can also be a sign of a heart attack. And then just being incredibly fatigued with activities can be another sign. I don't want everyone to worry about their indigestion after a spicy meal. We're really, talking about something that feels different to you. And I want, everyone just to think a little bit about that as they get to know themselves and their bodies the best. If you don't feel right, it's important not to ignore that and get it checked out. And when we have plaque buildup, so we think of those big arteries that line our heart muscle. So this graphic shows a picture of our heart muscle. The arteries that are on top are called epicardial arteries or coronary arteries. And these are the ones we're talking about when we worry about plaque buildup and heart attacks. But these arteries actually then branch out and go into the heart muscle, and I'll get to this next. But this graphic just shows kind of what plaque buildup looks like in an artery. And then in an acute heart attack, it is not uncommon to develop a clot as part of this, where something in the plaque gets roughed up and causes a clotting cascade, and we develop an acute blockage, and that's how people have acute heart attacks. In women, it is not uncommon to have signs or symptoms of a heart attack, but actually not have any significant blockage in those larger arteries. And that is termed INOCA, or ischemia and no obstructive coronary artery disease. For years, we would think of this as not being signs of a heart attack, but in reality, it just, I think, speaks to the differences in men and women. Men tend to have those larger arteries have their blockages, whereas for women, it's not uncommon to have these tinier arteries that feed off those bigger ones, cause all the same symptoms of a heart attack and evidence of it, though the larger arteries may not have a blockage in them. We also have more of a tendency towards spasming of the artery, which can cause a heart attack, and what is called microvascular angina. So those tiny little arteries can give you angina symptoms, but they get treated with medicines because they're too small for things like stents and other surgical procedures to intervene on. And this goes to show that same type of graphic and some of the conditions that we see that in. Again, in women, often older women with many of the traditional risk factors, but not showing the larger arteries having a blockage. Similarly, there is a syndrome called Menopause, which essentially is a sister issue where you have evidence of a heart attack, though the larger arteries do not show a significant blockage in them. And that, again, is more common in women. And we see that with the heart spasming, those smaller blood vessels. In some cases, it may be that the artery has already resolved that blood clot on its own. And it is important to treat those as heart attacks and be as aggressive as we can with medications to treat that in women. I included this because I think it is so important as we have discussions about women to talk a little bit about some of the differences in gender equality that you might see in medicine as well. And unfortunately, at the global and national level, we know that many women will get different treatment for heart attacks and for things like congestive heart failure than you may see in a male population. And this graphic by the American College of Cardiology just kind of goes through some numbers of what we may see in this country. I am very happy to say, though, that I think in New England, most of us would not find this to be our experience at all. But again, cardiovascular disease is the number one cause of death in women. It causes 1 out of 4 deaths. Despite that, there are gaps in care, and women tend to not do as well after a heart attack. They may not do as well after bypass surgery. They have higher rates of congestive heart failure after a heart attack, and overall higher rates of dying and having symptoms after their heart attack. And while some of these gaps in care may be more regionally awareness of what heart disease looks like in women, definitely another part of it is just not having research specific to women. And many of our trials in cardiology and in medicine in general really look at the experience of men and extrapolate that women will behave the same way. And we know that that doesn't always hold true. So there is a push at the national level and with many of our national cardiology institutions to include more women in our research trials and to really look at gender-specific treatments for many disorders to see if really women behave the same way with medication treatments so that we can appropriately be giving the treatment that everyone needs. And despite the higher rates of death and heart attacks occurring In many institutions, women may leave the hospital without being on a cholesterol-lowering medicine. They may leave without being on a blood thinner for things like atrial fibrillation, or not have their blood pressure managed as well. And I included this graphic because it just goes through some of the, I think it illustrates in a different way the gaps in care for women. And this speaks to death rates for women older than 35. And you can look really nationally, there is such a stark difference in how many women may be dying per 100,000 of the population. Happily, in Massachusetts and New England in general, our heart disease death rates really are not significantly elevated or altered compared to many other parts of the country, like the South, where you see just this predominance of women who are dying from heart disease. So just getting back to risk factors again, I want to talk about the many ways in women in particular we may have increase in cardiovascular risk factors. There are the established risk factors that we've talked about, like diabetes, high blood pressure, high cholesterol, being overweight and having an unhealthy diet, or smoking. But it's really important to also remember that socioeconomic factors, health literacy, depression and psychosocial factors, and environmental risk play a role in developing heart disease. And then gender-specific factors that occur during pregnancy, and things like premature menopause, polycystic ovarian syndrome, and other types of autoimmune and inflammatory disorders can increase our risk of heart disease too. And these are great things to bring to your regular providers to really talk about what your personal risk profile may be and how we can help you stay as healthy as possible. And this goes through a little bit more of the same type of concept. So we know that heart disease is the leading killer of women, and we want to really kind of change the focus away from not addressing this to thinking about how we can tailor care, tailor research. Amazingly, we need to destigmatize the conversation for many patients and women when they go to their primary care provider or in the hospital. And a number of women actually find it embarrassing to talk about their heart health, or embarrassing because they don't want to talk about their weight or other risk factors that may be there. And it's important to make sure we're including routine heart checks as part of your, including routine care as part of your heart risk check, and make it a priority when you have your annual visit to discuss those things with your primary care provider. And then invest in research and physician education and training, which I think kind of goes hand in hand with promoting heart health in women. And I think there are some great resources at the American College of Cardiology, as well as the American Heart Association. The American College of Cardiology has a patient website called cardiosmart.org. And I love this graphic because I think it's so important to be your own heart hero, to know what your risk factors are, and to really be a proponent of your own health. So I wanted to include this just to talk about those topics again, and really make sure to encourage people to discuss their heart disease risk with their regular providers and get educated about what they can do to make themselves healthy or healthier. And this is from, again, the American Heart Association, which also has some great programs. And we probably are familiar with the Go Red for Women, with a little heart at the bottom, but they have some great other resources to help people make changes in their life. And on a lighter tone, I found these funny Valentines from a heart institute in the Midwest, which I guess they used around Valentine's Day last year to promote heart health. So I thought we would end on a lighter tone than some of the things that we had been talking about. So I thought this was cute with let's slip into something lacy. Roses are red, violets are blue. Let's exercise daily and eat healthy too. And hey, Valentine, let's get our heart pumping with 30 minutes of cardio. So thank you all for listening. And I have gone over, so I apologize.
That was great, Dr. Chaudry. Thank you very much. And for being a proponent of women's heart health. It's really wonderful. And the Valentines were adorable. I think I want to steal that idea.
Yeah, I was thinking the same thing. Hopefully I haven't depressed people too much. I was reading all this and thinking, geez, as someone in perimenopause, I don't know how I feel about losing estrogen.
Right. Yeah, it definitely sounds challenging. But you covered a lot of topics, a lot of it, and you know, information is power. And we do have a couple of questions in queue if you want to take a few minutes to answer them. Or
absolutely.
So Amanda has a question. Does the cause, in quotes, of menopause impact the effects? Can you speak to the need to avoid spicy foods? She thinks this is terrible news.
I know. I thought so too. So, you know, the spicy food issue, I think, is mainly because some people will have worse hot flashes and symptoms. There certainly isn't anything wrong with spicy food, and it's not going to hurt you or increase your risk of other diseases. I think a lot of it just depends, like many things, if it is a type of food that makes you feel worse, especially when you're going through menopause changes, you probably just want to avoid it until you get through that. The cause of menopause is important to a degree. So, you know, definitely people who have premature menopause or surgical menopause at a young age, we know that that confers a different type of risk than when you have natural menopause. The thought right now is that a lot of that is timing related, but I think we need to understand that better. And it is remarkable to me that, you know, despite women making up half the population, we still have so many buckets of menopause, hormonal changes, and you know, cardiovascular disease that we don't completely understand how all of that works, and really even in detail what is happening as we lose estrogen.
Thank you for that.
Sure.
Amanda did have a response. She says, "Hallelujah! I will eat my vindaloo with relish." So she's very happy about the spicy foods anyway. Luzman has a question. I'm curious as to why a high serving of whole grains aren't these turned into sugars?
So the high serving is a little bit you have to be a little careful with it, because in this particular diet, a serving is an ounce or a piece of bread. So even though it may sound like a lot saying 5 to 6 servings, really, you know, if you're having 5 ounces of a sweet potato or a complex carbohydrate like a farro, you're really not getting a ton over the course of the day. Not 5 servings the way I think most of us would think of a serving.
Right. Thank you for that. I'm looking through the Q&A box. If anybody else has any questions for Dr. Chaudry, you can type them in. We'll just give you a minute. And, I'm just going to scroll through. I guess Luzman was asking about were the studies all women specific? She wasn't really clear, but it seemed like your slides at the end were definitely specific?
Yeah, so the kind of larger trials looking at blood pressure and cholesterol guidelines, those are mixed trials. But the numbers that I was talking about for heart disease risk and some of those other specifics really are about women.
Excellent. Linda wants to know, do you consider age 48 premenopausal with a hysterectomy having been done?
So if you have your ovaries, then even though you've had a hysterectomy, you certainly may be perimenopausal, but it doesn't necessarily mean that you're in that higher risk category of someone who's already postmenopausal. The hard part is really you should still have the hormonal modulation and estrogen if your ovaries are there. But if you've had both removed and you're under 50, then yes, your heart disease risk is going to be a little bit higher than someone who is over 50 and going through menopause.
Very good. I kind of had a follow-up question to that, like, are women who have menopause later in their 50s, would they have a lower risk?
Yeah, so this is one of those things where, as annoying as it is to still get your period, the later you can have menopause, the better from a cardiovascular standpoint. The hard part is we don't get to choose that, right? So much of that is really based on our genetics and our family history. And it would have been great if we could just pop an estrogen pill and have it do the same thing. But that doesn't seem to be the case.
Right. Well, thank you for your work tonight and for your presentation. Seem to have come to the end of our questions here, but a lot of great information. I thank you very much for your time and expertise, and we look forward to the next event for our Women's Heart Series.
Great. Thank you. Thanks, everyone, and have a good night.